I'm joined by three experts who can speak. We're going to talk about ageism in healthcare. And we have three experts. UCSF is in the house in a very big way. Our panelists can talk about the ways that ageism impacts healthcare in various dimensions. So we're talking about medicine, culture and community, and the built environment. And I'm going to explain all of that in a sec. I am joined by Dr. Louise Aronson, who is, as you all know, a renowned geriatrician, writer, educator, and professor of medicine at UC San Francisco, and the author of the New York Times bestseller and Pulitzer Prize finalist, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. And this is our author panel because we also have Dr. Stacy Torres, who is an assistant professor of sociology in the Department of Social and Behavioral Sciences at the UCSF School of Nursing. And she studies and writes about aging, gender, mental health, social relationships, and urban communities, and is the author of a brand new book, born only last Tuesday, At Home in the City, Growing Old in Urban America. And on screen, rounding out our UCSF triumvirate is Kristin, Amlie, the principal ergonomist. I did not know until days ago that there was such a role, and head of the Ergonomics and Human Factors program at UCSF. Kristin is a physical therapist who trained in Norway and specializes in ergonomics, human-centered and universal design, inclusion, disability, and aging. We're going to dive right in. Dr. Bob Butler, who of course coined the term ageism, called aging the neglected stepchild of the human life cycle. And I would like to go through with each of your domains and just start with you, Louise. How does that manifest itself, that neglect, the neglected stepchild, how does that manifest in medicine?
Well, you can basically see it top to toes. So if you think about healthcare, it is focused on children and adults. And yet, if you look throughout history, there have been three broad categories of human beings: children, adults, and elders. If you look at healthcare in particular, the group that uses the most healthcare per capita is older adults. Look at cave paintings and you will see these three different age groups depicted. Look throughout history, it's all there. But what do we have? We have adult hospitals and children's hospitals. If you're a child or an adult, we have specialists for each of your body parts. And actually these days, we have subspecialists, right? This is the neurologist that will deal with the seizure in your left hemisphere. But really we focus on those two categories. And what do we have for older adults that's specifically for them? Well, we have things like nursing homes, right? That many of us will end up in, but none of us want to end up in. We have a very small group of specialists. We also have training programs where, for instance, I'll just take doctors because I know that best. It's 4 years of training. Of that, about 3 months is devoted to children, about 2 weeks to older adults, and the rest to adults. So really, soup to nuts, it is an ageist, it's a neglected stepchild.
Okay,
I could go on forever, but I think I'll stop there.
That's a good intro to sort of the deficits and the ways ageism presents in medicine, just at the very top level. And Stacy, could you do the same for us in talking about how ageism manifests in community and public spaces in terms of the health of older adults? Yeah.
Yes, of course. Thank you so much. So I like this idea of thinking about the neglected stepchild, maybe because I'm one of 4 girls. So there's always somebody that was like musical chairs. Somebody was always on the outs. And I think just within sociology, which is my discipline, age has been called an et cetera category. It's not something that's top of mind usually with race, ethnicity, gender, class, it's sort of like, and et cetera, et cetera, et cetera. And like many sociologists of aging, I fell into aging. It wasn't like I, in my mid-20s, was, oh, I'm going to go embark on studying older people. I actually didn't have a lot of older people, even in my personal life. I come from a working class background, and I always joked with some dark humor, nobody really lives that long in my family anyway. And so I was really much more interested at first, I thought, in public spaces and third places. I'm from New York City originally. I stumbled upon this little mom and pop bakery where I was like the student in the corner working on my MFA thesis at the time. And I noticed that me and a lot of older people that were there, mostly in their 70s and 80s, we had a very flexible schedule. So I would kind of show up, roll out of bed at what time, I was waking up at those hours, and they would as well. And so then I was thinking about, well, why do we all like this place? And why are these older adults especially drawn to this place? And I think of, well, we had a lot of connections. I was in my 20s though, and they were decades older. We weren't the joiners. And so I think in thinking about the neglect of age in our society, before we heard the term age segregation, that there are a lot of zones where people are not interacting. And so these older adults who were not the joiners did not want to go to an institutional age separated place like a senior center. They wanted a place, even though there were a lot of older people there, it's not that they didn't want to necessarily hang out with older people, but they didn't want to be shunted in some place where they had to be a member, or they had some obligation, or it was like only, again, these age cutoffs. So I think that that's something that I think about, that neglect and the needs that were met there. And then also, unfortunately, due to gentrification in New York City and a lease that wasn't renewed, the place closed down and they felt that loss of space. And it wasn't like there were a whole bunch of other alternatives, although New York City being kind of an outlier in terms of its urban density, thankfully, they were able to regroup in other places. Even if it wasn't quite the same arrangement, they were able to find other points where they could connect and build social ties and community.
And you got a whole book out of that, which is a wonderful.
Yeah, my dissertation advisor said, you never thought you were going to spend so many years in McDonald's and this was going to become your project. And I was like, well, maybe actually exactly I did, just because I'm kind of I'm a lurker, and I'm kind of a nosy person. I'm an eavesdropper. And so I would say about these spaces, I don't want to just say that they were good for older people. They were good for me too. In my early and mid 20s, I think I was actually more isolated than some of the older people. I was kind of doing this MFA program. I didn't have a lot of friends my age because I had so much caregiving that I was engaged with for my father, who had multiple cancer diagnoses, for a sister who had multiple disabilities. So I would say, I think the way to, there was a comment in one of the earlier panels about how do we, embrace the language of we versus they. And I like to, one, I always state my age, I'm going on 45 as well. But two, I think just recognizing those mutual needs, that we all have this need for connection and for belonging and for recognition and attachment. So yes, I spent a lot of years in McDonald's and I got a book out of it. So not too bad.
Kristin, could you talk to us about ageism in buildings and in design and in the physical environment? What do you see, and how do you try to correct the deficits that just seem baked into our built environment?
Sure. Thank you for asking. Does this sound okay?
Yes.
Okay. I had an echo on my part, so sorry. I will say that the echo is really disturbing. Is there an AV tech?
Yeah. Why don't we take it back in the room? We'll get that echo taken care of, and we will come back to you with that question.
Kristin, if you want to just turn your volume down when you're talking, you shouldn't have the echo anymore. Can you hear me?
Mm-hmm.
There you go.
Okay, I tell you what, we're gonna continue the discussion, and we'll deal with the feedback problem. Let's see, Louise, could you just talk how healthcare ageism fits into the broader picture of ageism as we've seen it in so many aspects of life? How does it fit in?
It's actually been fascinating. I guess I would have said a while ago that, you know, every institution is part of our culture. And so if ageism is baked into the culture, it's going to be baked into healthcare. What I've heard today has been interesting in two regards. Well, maybe more than two, but as healthcare has become corporatized, I think we haven't necessarily changed our tactics for dealing with that. Some of the things people have said about you need to make the case economically to people, because they're really thinking just economics and just numbers. At the same time, when you provide evidence, so in medicine, we speak a lot about evidence-based medicine. Well, the evidence is that older adults are disproportionately harmed by healthcare. The evidence is that they lack the access and services that other people get, the specialists, and that doesn't make the case. So one thing I'm thinking is maybe we need to speak business speak a little more effectively and look at some of these gaps.
What would that look like? What are we talking about? Market segments, or how would business speak? What would it sound like in a medical setting?
Well, I guess people have been talked about themes and speaking to pain points for the C-suite. So if you feel like that, we get emails now constantly in business speak. So a service profession and you entered it because you wanted to take care of people and that was the mission. That is no longer the mission. And when we speak that language, they cannot hear us. They do not care. Their mission and our mission is different. So I think we have to speak to their mission about populations and throughputs and opportunity. And this might be who was the glasses guy about inability to make money. I feel you on that. But maybe we could render the positive with the negative. And one of the things I tried to accomplish with elderhood is to say that elderhood is a decades-long phase of life with huge amounts of diversity, no different than childhood or adulthood. Who's most miserable? Sandwich generation people in their 40s, sorry. Would you want to be a teenager again? I know some people would. I personally would say no. So how can we paint this larger picture and pull in some of the really positives about the longevity economy without further disrespecting and othering the people at the later stages? Because I feel like sometimes in these efforts in healthcare where, lifestyle medicine or cosmetic medicine is huge, but geriatrics is tiny, what we're doing is reforming the sort of 45 through 70 category at the expense of 70 plus. And so we're doing to the 70 plus what those of us in that earlier category don't want done to us. And I just like us to aim higher, and that had very little to do with healthcare. So sorry.
Bring in the voices of the people who are actually the user, the healthcare consumers in great numbers. So that makes total sense. Stacy, I want to get to you in a second. Kristin, are we good on the audio?
I am. Can you hear me?
Yeah, sure can. So I wanted to go back to
Great,
the
thank
original
you.
question.
Sorry for the technical difficulties, and it's actually a great example of ergonomics, because what we look at for ergonomics is how do people function within systems and environments, including the built environment, which you asked about. And I will say that in terms of ageism being the stepchild of the built environment, I will say that a lot of things are a stepchild of the built environment. And so people are often not thinking about the variation, the natural variation in humanity when they're building buildings. They have an idea of, how do I make this building work for me or for a random average person, which doesn't exist. And so we use design processes called universal design, where you're designing
Tell us
building,
what that means.
System, it can be equipment or a product to meet the needs of the widest variety of people in terms of ability, size, and age. And I think that's really the way forward, is to really think, how can we think about all of the users of the system, all of the users of the building. So this could be the patients, it will be the people working there. When we talk about healthcare and ageism, we have to think both about patients, the community visitors, the families of the patients, and also the healthcare providers and the staff who work there, and the aging workforce, including the people who are cleaning our buildings. And so one of the ways that we do that, and I do that, is try to get involved as early as possible in the planning stages. And right now, not as many people are talking about using inclusive design. And so I'm one person with a population of over 30,000. And so I think the more people we get involved in looking at buildings as a space where everyone needs to function and optimally thrive at their best, the more people we need talking about this and thinking and sharing their perspectives about this. Lived experience is really important. Diversity, equity, and inclusion has made a lot of headway in many realms, but I don't see that as much with disability and with ageism, and there's some crossover. And we know that according to the CDC, over 40% of people 65 and above will have some type of functional disability. So I think there's a lot we can learn from accessibility and the disability community as we're looking at designing buildings.
Can I give?
Go ahead, Liz.
Could I so part of how I met Kristin was that I took my 91-year-old mother to one of the fancy new neurology buildings. I guess I'll just say at our medical center, not yours. And it was a gorgeous building, and you walked in and there was this immense atrium. Now, we were there for the movement disorders clinic. To get to the elevators, what you saw when you walked in was this beautiful staircase, which was not going to be helpful. And the elevators were somewhat hidden. Now, also hidden was any signage, which was particularly interesting because also in this building was the memory and aging clinic. And then we got up to the clinic, and they had these chairs that were really low and didn't really have arms for people. So I was like, okay, she can get down, but now what? And then she went to the bathroom and she couldn't open the door. Like, it was too heavy to open. And then it's like slamming shut after her. And I'm like, hello, are you okay? And so this is why we need people like Kristin, because this was an entire building that was mostly built for older people. So imagine what the rest of the healthcare center is like.
Thank you. That was the example, many examples in one outing. Stacy, I want to talk a little bit about what you found just out in the wild, in the wilds of Manhattan.
That sounds very exciting. I'm
Yes,
going to
well-
put my Indiana
well, you
Jones
are-
cap on.
You are millennial, so we're looking for some excitement here.
I'm an ex-ennial. I was born in 80, so that's
Okay,
that cusp
all right.
generation. But thank you.
Your book, At Home in the City, looks at the lives of older adults who turned a Manhattan coffee shop into what you described as a public living room. And I'm curious what you discovered about the importance of gathering spaces for older adults.
Yeah, it's really interesting, and it aligns, I think, a lot with the discussion about inclusive design, universal design, spaces where people and older bodies or people with disabilities or chronic illnesses can feel comfortable. And I count myself among that group. I have an autoimmune condition called Sjogren's. I've had it since I was 26 years old. Creates a lot of fatigue. It creates like light sensitivity. Like, I'm very sensitive now to fluorescent lighting, all sorts of different things. So I would say, the spaces, and I think COVID has also done this to me too, has never made me more spatially aware in terms of like having space where you are on a periphery. And in this bakery, one of the things that was kind of so wonderful was that even though it's New York City, spaces are more compact, they're more crowded, that there was ample space for people to feel comfortable, to park their walkers or their shopping carts in a corner, to dip in and out of different discussions, to sit in a chair that was comfortable. Like I've, paid a lot of attention over time to different trends, like coffee shops, like Starbucks, removing seating, or the seating is like become, I find, more uncomfortable over time. Like I remember when Barnes and Noble's bookstores first started to expand in New York City in the early 90s. Like you would sit like this comfy chair. This is a very comfy chair. I want to take this chair home. Like this is a place where you want to linger, where you feel comfortable. And over time, it's business interests don't actually want people to loiter. They don't really want people to spend too much time. And that impacts younger people as well. Like try to find an outlet in a coffee shop and you're like hunting around in the wild. It can be very challenging, sometimes depending. And, I understand all those things. But I would say the elements that Louise and Kristin were mentioning about spaces where you feel comfortable, that you can access, that you can walk to, that feel safe, that feel accessible, that have a restroom. These are all things that people of every age you would think want, but especially, as you're getting older, as I'm getting older, look, I have a dry mouth condition. I am drinking a lot of water. If I go to a coffee shop and there is no restroom, that place is off limits to me. Like I just can't, I can't handle it. So I think, understanding that these are not only, I think, important values morally to welcome as many people into a space as possible, but for businesses, I do think it is important. I do think that it affects their bottom line if it's a place where you don't want to go after a while. I mean, Starbucks, I wrote an op-ed about this for the LA Times last December. Starbucks has been trying to retool its business plan, like make it more like community oriented, blah, blah. I will say blah, blah, blah. They're going to bring back the Sharpie, or they already have the Sharpie markers where they write your name on a cup. But if you were not really, really welcoming people in a real way, and just, own it, I guess. So all to say that even within the small world that I spent so many years in New York City in the book, this lovely coffee shop, bakery, not a perfect place. I mean, it wasn't like, the customers would joke about like the holes in the tablecloth and the rickety tables and the chairs that were shaky, but with affection. Once that place closed, a new place opened up, and it was shiny and it was sleek, and they removed a lot of the natural light. They put kind of an exterior cover that made it a lot darker. The thing about doors, very heavy doors, difficult to open. I remember when some of the regulars and I went to try this place out, there was a woman with a walker who just had to kind of stand outside until somebody noticed her, customer coming out, to have that door open. So, I mean, even like a handicap, like the button, button to automatically open the door makes such a big difference. And I mean, I'm not an urban planner or design expert, but I think just when we're designing communities, buildings, especially healthcare buildings, why don't we have a field trip of people of different abilities just to kind of walk through and sort of say, like, test the place out? I remember many years ago, I wrote another op-ed for the San Francisco Chronicle about pedestrian safety in Oakland. And I was comparing some of the, the challenges. And I, suggested, like, are people walking here? Like, do you walk? Because I walk a mile to BART, every day, because I don't drive. New Yorkers, we don't really learn how to drive in the city now. We have congestion pricing, so especially not learning to drive now. And, there were a lot of really dangerous spots to walk around. And over time, these things accumulate and they become socially isolating. Like I really have thought
And
about
that
where
connects directly to healthcare, right? If somebody's socially isolated, there's a whole cascade of health consequences.
Absolutely. I mean,
Right.
ageism itself is has consequences for mental and physical health. That's well documented. If you don't want to go to a place, if you don't feel comfortable, if you don't feel seen and respected and listened to over time, and I found this with my small group of participants, people stopped going and weren't having their medication refilled. And so, if we want people to be, I'm not a clinician, I don't have a nursing degree or a medical degree, but I've heard this phrase, patient engagement. We want to activate patients. We want them to be partners. partners. We want them to like go to all their preventative health care screenings. These things are expensive over time. One of my participants who felt very condescended to, out of all places, the Veterans Affairs Hospital Geriatric Clinic, so didn't want to go there. And, you know, he had already had heart attacks and wasn't getting his medication renewed. And it was only because of the people that he would hang out with, these older people, where they were commiserating about their aches and pains and counseling each other and listening to each other, that they convinced him, like, you got to go back there, Eugene, or, you know, you need your medication.
What is meant by elderspeak in healthcare? Give us some examples.
Well, I think Martha sort of alluded to a variant of it, which is when they started speaking to her rather than her mother.
Okay.
A good test, you know, it's also sort of speaking down. Okay, honey, here are your medications. Like, you don't get old enough that feels good. You know, like that's if you're a child, okay, maybe. You know, and honey has its sexist components potentially as well, but it's a baby voice. It's the voice in which we speak to kittens, you know, and small children. And there's a sing-song high pitch, which is actually kind of ironic because the most common forms of hearing loss with age are to the higher registers. So how to increase the likelihood that the person won't hear you and therefore will have to sort of make up an answer, which will confirm your perhaps false notion that there's something wrong with their brain. So yeah, really a talking down and infantilizing.
Well, we've talked all day about action and trying to find some positive solution. So it's magic wand time, and we'll just start. Stacy, let me start with you. What is one action that we could take in terms of ending or minimizing social isolation that so many older adults feel that leads to a cascade of health issues?
Yeah, well, I mean, I think I'm gonna pick twofold. I'm gonna kind of give a twofold answer because it's just too tempting. Well, I'll make it quick because happy hour is waiting. So one, I think, you know, bolstering our social infrastructure, community places, our libraries, our coffee shops, our parks, including this green and blue space. And so where people who aren't the joiners, maybe not heavily engaged in, you know, spiritual community or a book club or senior center, have some place where they can go to hash out a lot of these issues, I think is one thing that's really important. I found, again, that people use these settings to sort of work out some of their frustrations or vent or get advice from other settings where they did interface a lot, like medical settings, where they had these interactions where they felt not spoken to, hurried, rushed, or confused. I think another thing that, again, I'm not an expert on medical training and what goes on in medical education, so maybe Louise can speak more to this, but I really think early and often, and it goes to sort of the pre-med, undergraduate education as well. We have many students at sociology who once wanted to be doctors and medical doctors decided no and come to us. But I think just sort of anti-ageism awareness, training, inclusivity, like just kind of, it's not the sexiest topic, you know, it's not something that maybe is even top of mind, but kind of integrating it, and maybe not like with a capital A, like anti-ageism, but maybe just like normalizing, okay, it's a social identity. This is all of the different arenas it comes up in, and not just, you know, aging isn't just older people, it's the entire life course. Like the things that happen when you're younger will affect the things that happen when you're older. Disadvantage accumulates. So I think kind of just integrating this earlier, so it's not something that I guess, you know, medical professionals are sort of built into thinking, oh, them, those people.
So aging is a natural part of the life cycle for the fortunate. And not a disease. That would be a good start. Let's see, Kristin, do you have any thoughts on what is an action we could take now if I pass the magic wand your way?
Sure, thank you. Actually, I'm going to choose partnership. And I think that by partnering with others who are doing some anti-ageism work, also other related work. So I'm involved with a lot of diversity, equity, inclusion, and accessibility initiatives, and they have been at this for a long time, and there's been some recent successes in that, more recently with disability and more also with racism and sexism and other isms. And I think that if the more we can partner with that and learn, use their lessons learned, and share information, because we're all coming from the same place, that this is all about humanity. And like Stacy said, it's important to normalize this, right? Like aging is normal, it's change. People don't like change. People don't often like aging. People don't like having limitations on their abilities. And so how can we reduce the stigma of that with a broad-based partnership? I also think that the intergenerational approach and really partnering with different people from different generations is important. If we look at UCSF, a lot of the students are really active and very verbal in terms of what their needs are. And I think if I look at some of the older generations, they're more hesitant. And so maybe there's lessons that we can learn in terms of partnering with different generations to really spread awareness. We recently formed the Ageism Awareness and Action Coalition. Both Louise and Stacy are members of that at UCSF. And I think part of what we're trying to do is really look at sharing that message and partnering with people across the organization to look at, internal and external communications, our healthcare system, our processes, how we're doing employment and hiring. And the more we can embed this message across different levels of the organization, generations, and other partners, I think the more effective we'll be.
Great. We have, as I promised you, this is not a complex.
I didn't get my magic wand.
topic. The magic wand is coming your way.
Okay.
I wanted to say that.
Because I'm really going all out.
Okay, Louise is going to go all out with the wand, and then we have just a few minutes for questions before we rapidly make our way to the bar. So, Louise, magic wand is yours.
Okay, magic wand first. This is never going to happen. So there's like a multi-billion-dollar longevity economy, right? Which is mostly about making wealthy white people who are already going to live longer than everybody else live even longer still. Now, I'm somewhat a beneficiary of that, but I would say we tax I can't say it here, out of those people and put it back into healthcare system, because one of the very many reasons other people don't get to be old is because the health systems in their neighborhoods suck. It's why they died more of COVID, they die more of heart attack, they die more of appendicitis, they can't get food, they can't go for a safe walk. So we tax the hell out of that, and it goes into the communities where it's really needed to more equally distribute resources. Sorry. You can see why I can't make any money in my life.
It's a sword. It's not a magic wand. It's a sword.
Yeah, it's a sword. Yeah. And the other thing would be we restructure the entire healthcare system, because right now they want you to be sick as hell. If you could need a transplant, they're going to make money off you. But you want to stay healthy, you want basic healthcare, you want a primary care provider who actually knows and cares about you. There is no money in that. So nobody at any age is going to get that. So it's bad pediatric care right through bad geriatric care. So I know I took 2 once, but she started it.
Okay. With that call to arms, let's open it up. We have just a few minutes. Do we have any questions? Yes, all the way over. Oh, over here. Way over here.
It's like a tennis match.
Yes.
Thanks. I would love to hear just how we show up as patients and health consumers to, in a not necessarily a confrontational way, but how do we show up to demand to be a partner and a collaborator? So what are your thoughts on that?
That's a jump ball. Who wants to take it?
I don't know. It's really difficult, because let's not downplay the power dynamics that are at play in every healthcare interaction. There are people, and I'm speaking from my experience as a chronic illness patient at UCSF, where I've received very good care, and also care that I've had to really push back on and really, advocate for myself. And that's been the situation at many different institutions. And so I think, trusting in your knowledge of your body and what you're feeling and the things that you need to express is one thing, in terms of making sure that the message that you need to get across is being listened to, and saying it again and again and again, and asking for what you need. And again, I come from a working class background where we were taught to really defer to authority. And I mean, you know, I've also gone to the, you know, I was a caregiver for my father for a long time, and he would just nod and smile at every appointment. And he had multiple cancer diagnoses, so this was really serious stuff. And then I would go home after and then tell him what happened. But in those experiences, I really had to say, oh, you're going to take his kidney out? How often have you performed this procedure? Because one person said, oh, enough. I'm like, well, what is enough? Because we're talking about my only living parent. And so, and sometimes you have to be confrontational. That doesn't mean that you have to go in with sort of, you know, the sword right away. But I do think that we need to, if this is a business and we are consumers, and this is a service, that we need to be bold in continuing to press on. So that's just one thing. I think there's so many other things that I could say that are probably more wise, but I will let Louise jump in there.
Okay, two things. Create the market. So at UCSF, the geriatrics clinic for its first 30 years did not keep a wait list. Why? Because so many people called and they couldn't meet the demand. Imagine if they had kept that wait list, and if every month they sent it to headquarters, C-suite, whatever you're supposed to call. Anyway, so if you know your child or grandchild gets to see a pediatrician, and you or your child, depending on what age you are, get to see an internist, why don't you get to see somebody who has training in your body and your priorities and your age group? Just keep pushing back, make a complaint that there is an equity issue here. And I've been saying this for years, and I feel like nobody takes me up on it. You have to make noise. You do not have to be rude. You just have to ask, and people have to keep asking, because once they see there's a demand, and instead everybody's so quiet and polite, and they get, you know, instead I get an email saying, oh, well, you know, that the primary care doctor has left, and so they've given my wife somebody who specializes in menopause. So do they know that she had menopause 33 years ago? You know, so really demand what is your right, what they are offering to others. I think that's one thing. And then when somebody says to you, that's because of your age, say yes and. My age puts me at risk for diagnoses. And at any age, people can be helped. Or somebody, I don't know that she's here anymore, but there's a story I like to tell about an old man with a painful knee, goes to see a doctor, doctor does the usual thing, says, well, that's your knee. You know, you're old, your knee is 96 or whatever it was. And the old guy said, this apparently really happened to Mount Sinai, by the way. Well, my other knee is 96 and it doesn't hurt a bit, right? So there's a diagnosis there and there's a treatment. So systemically make noise, and one-on-one say, I appreciate that, and I still need help because my knee still hurts and I need to be able to walk.
Thank you. We have one more question. Okay, yes, please.
Thank you. My name is
Oh,
M.T.
sorry.
Conley, and one of the most wonderful scenes in Louise's book is about her being an assertive medical consumer on behalf of your father. So I urge everybody to read it if you haven't. My question is about systems change and about building political constituencies, which is essentially what we need to do to move the needle more effectively. And we have the data that geriatrics improves health, improves independence, reduces costs. And how do we deploy those data more effectively in this era of, dare I say, a Department of Government efficiency? I mean, it does save money for Medicare, it saves money for insurance companies, and yet we haven't managed to persuade it, and it helps human beings. So how do we connect those dots?
Somebody said something earlier, I think it had to do with the film industry, where you give them the data and they literally can't see it. And I was like, oh yes, we see this in healthcare also. It's evidence-based, except when the evidence goes against your prejudices, and then it's sort of not convenient. So this is why I think people need to make noise, because consumer demand, I mean, one of the things about the corporatization of healthcare is that ratings, online ratings, Yelp things, make noise. That's the sort of stuff they respond to. Apparently evidence isn't so helpful. But I think if we can provide evidence for them making money, as opposed to them providing better care, that's going to sell better in the current era, which I hope to outlive, but nevertheless, that's where we are now. So I think those things, and then the policy level, but it's a little hard to go there this week.
We're gonna wrap here. I know there are other questions, and I feel like our very patient panelists will be gettable either here or across the way at the bar. I want to thank Kristin, Amlie, Dr. Stacy Torres, Dr. Louise Aronson. Martha, thank you for the lovely welcome back. And thank you all.